All right, great. So I'm going to talk to you a little bit about window of opportunity studies. Those are my disclosures. And I think the reason that we're talking about this today is that Dr. Grandis mentioned a couple of these trials kind of offhand in her talk this morning. But I think that clinical trials are something that don't come necessarily naturally to surgeons. In even making this slide, I had to look it up again and go, okay, what is phase 0? What is phase 1 and 2? These are things that are very evident to clinical oncologists most of the times because that's where the trials reside. Because they're often checking a therapy such as a drug, and they're getting a new drug and then trying it versus the old therapy. For us, it's uncommon to have a surgery where we randomize, surgery or no surgery, or this surgery or that surgery, because most of us have an opinion already on this. And it's also hard to convey that to a patient that we're going to try to do something where we're going to flip a coin, we might do a surgery or might not. So those trials have been typically very difficult to get off the ground. But I'm going to discuss this window of opportunity study, which really heavily relies on the surgeon to actually implement these trials. So to run through this quickly, a phase 0 trial is really exploratory. It's really just a question of we just want to make sure that it's safe, and we want to measure the pharmacokinetics, usually their blood test, give a patient a drug, see what the blood level is. It's very simple. A phase 1 is predominantly centered around safety. So these are small cohorts of patients, and you may do often a dose escalation study where you're giving a single dose for 3 patients. Then you see how they do, get some pharmacokinetic data, and then you say they did fine, so then you up the dose a little bit for the next 3, and the next 3 you go up and again. So they're basically dose finding, making sure that it's safe for patients. Phase 2 is where we get to the part where it's more exciting, where you go, well, there's a signal that this is going to work, and we're actually looking for efficacy. But this is not typically a randomized component. This is simply where we're taking 25 to 100 patients. We've now gone through the phase 1 to find the dose that's safe, the maximum tolerable dose, and then we give it to this group of patients, and we look for some sort of endpoint of treatment. And it's usually a response, something shrinks, or a quality of life improvement like pain or something like that. Phase 3 is sort of like the gold standard where you've gone through all these other phases, and now what you're doing is you're randomizing. You're saying, I'm taking this intervention plus versus the standard intervention. And then I'm going to actually compare the two, both in terms of response, quality of life, or whatever your endpoints are. And this is what usually precedes a drug going to market or a procedure going to market. So if you think about it, all these phases requires a lot of time. So we basically have to go through all these different steps to finally say, I am now going to start using this, or this is now going to become standard of care. So we talked about immunotherapy, for example, and really where this came from is phase 2 studies where they're looking at safety and a little bit of efficacy, but they've not necessarily randomized it to other studies. So only now they're doing phase 3 studies to look at after patients have received a lot of treatment. So this is in the recurrent setting. But the question is that we're actually getting data that says that it's actually meaningful and beneficial for these patients. So now what? Do we have to then do a whole nother phase 3 study to bring it up closer? Should they get it up front? Should they get it right after surgery in combination with radiation? And these are questions that we don't know, but it would take a long time for us to figure it out if we had to do this drug by drug. So this is where the window of opportunity study comes about. The patient population in this case is a little bit different. So we're talking about curable patients. So these are patients who, we normally have a design algorithm for how to care for them, but we don't know necessarily if these drugs such as immunotherapy might be helpful in this scenario. The other thing that's beneficial to the window opportunity study is that these patients are typically going to go to surgery, so we're going to get a lot of biomarker data available. So if you think about that patient who has recurrent and metastatic disease and they get a drug, the response is basically on a CT scan, you'll see the metastasis shrink up. But we don't learn anything about that patient. We don't know why that tumor shrunk and why it didn't work in another patient. In this situation, we actually are going to get all this tissue and tumor available to us so that we can study it in the lab and determine who's responding and who's not. So the difference also is that the duration here is often days to weeks. So we're giving this, again, to the curable patients where they're going to get surgery. So it may be a 3-week lead-in where they take a certain drug or whatever it might be. And then we're generally not going to delay the curative treatment as a result of introducing this up front. So the endpoints are not the same as necessarily looking at radiographic response, although you might experience some of that. So the tumor may shrink a little and we can document that, but we're not necessarily expecting that or demanding that of this treatment. What we're really wanting to look for is what is happening inside the tumor so we can learn something about it. So it may be a little hard to read, but this is just an example of a window of opportunity type of study. So this is not our study, but the idea is that when you meet the patient, it has to be on your mind. So in the head and neck world, it's usually the head and neck surgeon who's seeing a lot of the patients up front, even if they don't need surgery. But we're sort of doing the intake, we're talking to the patients, and we're trying to determine a treatment plan. So if we have this in the back of our mind, then right at this point where we think, oh, you know what, this patient, they're going to need surgery. It's an oral cavity cancer. It's a T3. I'm going to need Dr. Knott to help me reconstruct this. It's going to take me 4 weeks to get them, to surgery. Then I can think, well, is there a window of opportunity study that they might qualify for? So in this scenario, this one they randomize, but oftentimes these window of opportunity studies may just have several arms. So you get arm 1, you get this drug. Arm 2 might be you get this drug. Arm 3, this drug. They're not necessarily comparing these arms and saying which is better. We're just trying to figure out within each of those arms what is beneficial for the patient. Then typically there's a washout phase of just a few days, maybe where they get 2 doses of drug or 3 doses of drug. In some cases it may be a daily drug and they get it until the time of surgery. But then we'll do some scans, we'll get some more blood tests, and then we go to surgery. And in surgery we're harvesting the tumor. What really is important is in this back end we can look at study endpoints such as tolerability. We can see whether the tumor shrank. And then in the lab side we can look at the biomarkers and see if those reflect exactly what's happening in the patient. So the benefits here are that we can actually use more cutting-edge compounds because in this case we're not using it to the bitter end, right? We're actually using it up front for a short period of time so they may not induce the same side effects as someone who's chronically been on a drug for months until it starts to fail. We actually can test many drugs in succession, so as we see patients we can roll them, close out the arms very quickly, and learn about those drugs very quickly. Again, these are treatment-naive patients, so they're not necessarily the ones that have been refractory to 5 lines of therapy. They may not be as ill as those patients because they received all these therapies ahead of time. The other thing is that by the time they've gone through this typical phase of drug treatment, they're pretty beat up and they've had maybe a lot of resistance develop in their tumor. So a drug that fails in that standpoint may be actually beneficial if we had used it earlier, but we would never know that unless we did studies like this. The disadvantages are that we're not sure that it's going to actually benefit that patient, but we are going to learn something for sure. And so some of the window of opportunity studies that we've designed actually follow with immunotherapy after their standard treatment. So there is a beneficial potential for their treatment. Obviously we have to be very sensitive that we're not giving them something that will disrupt their surgical plan, something that won't cause wound healing problems or make them too sick to undergo the treatment. So these are drugs that have been typically used in other patients that have already gone through that dose finding. The logistics are challenging because we have to move very quickly, so it has to be on the surgeon's mind. It can't be something that we wait a couple of weeks and go, oh yeah, maybe we can give them that drug, and then it's another 4 weeks. We don't want to do that because these are curable patients. So we're actually implementing this right the moment we see them. We have them see the medical oncologist, talk to the research coordinators, but we have to have that team in place. And then the biomarkers, we don't always know what we're looking for. So some of this is exploratory, but I guess I would submit to you that if we didn't do it this way, then we would never know what these biomarkers are because we never get an opportunity to get this data otherwise. So thanks for your attention, and I'll take questions later. Thank you.